Naltrexone is a medication that is based on a molecule that attaches itself to the brain's natural opioid receptors. The body actually makes its own opioids, some of which are called endorphins. They are involved with various aspects of normal behavior like maternal bonding, stress, and pain response. When these receptors are stimulated by opiate-like drugs such as heroin, fentanyl, oxycodone, it can cause relief from pain, contentment, and euphoria. Prolonged continuous use may lead to physical dependence and/or addiction. It turns out that alcohol stimulates these same receptors, secondarily leading to brain dopamine release, which activates the pleasure and reward centers that modulate addiction. Naltrexone blocks the brain's opioid receptors. While chemically similar, it's pharmacologically different from the fast-acting naloxone, which is used widely to rescue people from opioid overdose. Naltrexone was designed initially as a daily medication to treat opioid use disorder, but researchers found that it also decreased alcohol consumption in humans who drank heavily. After similar positive effects were demonstrated in larger, vigorously designed studies, it was shown that naltrexone was relatively safe and well tolerated. The FDA approved it for the treatment of alcohol use disorder in humans. Naltrexone can be taken orally, that is by mouth, or injected into the gluteal muscle in a long-acting formulation that stays active in the body for up to a month. It's been shown to improve abstinence, to reduce alcohol use, and to prevent relapse to heavy alcohol use. It has also been shown to reduce alcohol craving and to block the positive brain activation and pleasure centers caused by alcohol cues and situations, especially visual and oral cues, during human brain imaging studies. Common side effects are mild nausea and headache, which usually resolve over time. Naltrexone, unlike disulfiram, does not cause GI side effects with exposure to alcohol. Importantly, naltrexone does interfere with opioid analgesics that are sometimes used to treat painful conditions, though this can be effectively managed with higher opioid doses or alternatives should the need arise. In rare situations, naltrexone may affect the liver, so people with decompensated liver disease should carefully evaluate the risks versus benefits before using it. However, the use of naltrexone in compensated liver disease has been shown to be safe. Oral naltrexone is taken once per day. Injectable intramuscular extended-release naltrexone is administered by a healthcare professional once every 4 weeks. The cost of extended-release naltrexone is much greater than oral naltrexone, however, though it might be covered by insurance. Extended-release naltrexone may help individuals who have trouble taking a daily medication. If a surgery or painful procedure is planned, it may be preferable to temporarily use oral naltrexone, which can be easily discontinued within 48 to 72 hours before the surgery, where opioid analgesic medications might be needed. Anybody who has alcohol use disorder may benefit from naltrexone. It is often beneficial to individuals who aspire to total abstinence, but is also effective and indicated for those whose goal is to reduce but not totally eliminate drinking. Naltrexone is particularly effective for people who have disruptive cravings when exposed to provocative situations or cues, and those who obsess about drinking. Finally, studies have shown that people who have AUD and tobacco use disorder, that is, daily smokers, may benefit most from naltrexone therapy. Individuals who regularly take opioid medications or non-prescribed opioids cannot take naltrexone because it will cause an opioid withdrawal reaction. Examples of opioid drugs include morphine, oxycodone, hydrocodone, codeine, tramadol, hydromorphone, heroin, fentanyl, methadone, and others. In addition, those with decompensated liver disease should carefully evaluate the risks versus benefits before using it. Naltrexone is well tolerated and works moderately well. Some people have robust responses and report that their cravings are completely abolished, and some reduce their use to smaller amounts of alcohol in moderation. Abstinence does not have to be the only goal, and a drinking harm reduction strategy may be acceptable to many patients considering naltrexone treatment. In the future, genetic testing might predict who will best respond to naltrexone, which might further enhance patient acceptance as well. Finally, pharmacotherapy for AUD should typically be done in the context of healthcare professional monitoring and encouragement, as well with peer support and/or professional counseling. Appropriate referral to an addiction specialist or counselor might be appropriate. Brief forms of counseling can be provided in primary care offices and is encouraged. The duration of treatment must be individualized, but for most people, at least 3 to 6 months is encouraged prior to assessing whether continued treatment or a medication holiday should be considered. However, many patients may benefit from medication treatment for longer than 6 months.